Weight loss is no longer just about willpower and diet plans. A scientific revolution is unfolding right now that's completely transforming how we understand and treat obesity. Peptide therapeutics, particularly GLP-1 receptor agonists like semaglutide, are achieving what was once thought impossible: 15-25% sustained weight loss without the risks of bariatric surgery. This isn't just another weight loss trend. It's a fundamental paradigm shift in medical science. What if I told you that the most effective weight loss compounds ever developed aren't stimulants, aren't appetite suppressants, but are actually mimicking hormones your body already produces? The documents you're about to learn from represent the cutting edge of obesity medicine, information that pharmaceutical companies have invested billions to discover, and that most doctors are only beginning to fully understand. By the end of this video, you'll have a comprehensive understanding of how peptides work for weight loss, which ones are most effective, their proper dosing protocols, potential side effects, and what's coming next in this rapidly evolving field. Peptides are short chains of amino acids, typically containing between 2 and 50 amino acids. Unlike conventional small molecule drugs that have been the mainstay of pharmaceutical development for decades, peptides occupy a unique middle ground between small molecules and large biologics like antibodies. Their larger size enables precise molecular targeting, but also creates challenges for oral bioavailability, which is why most weight loss peptides require subcutaneous injection. What makes peptides particularly valuable for weight management is their ability to mimic natural hormonal signals in the body. Our digestive system naturally produces peptide hormones that regulate hunger, satiety, and metabolism. The gut-brain axis, the biochemical signaling between your gastrointestinal tract and central nervous system, heavily relies on peptide messengers to communicate whether you should feel hungry or full. Modern peptide therapeutics essentially hack this communication system. The development of these compounds wasn't accidental. Scientists studying type 2 diabetes noticed that certain gut hormones not only regulated blood sugar, but also influenced appetite and weight. This observation led to the development of glucagon-like peptide 1, GLP-1 receptor agonists, which were initially approved for diabetes management before their profound weight loss effects were fully appreciated. Advanced techniques like peptide MS-MS fragmentome analysis have enabled scientists to study how peptides break down in the body, allowing for synthetic modifications that significantly extend their half-life. For example, natural GLP-1 would degrade within minutes in your bloodstream, but semaglutide with strategic modifications lasts for approximately 7 days, enabling convenient weekly dosing. The control center for appetite regulation resides in your hypothalamus, specifically in the arcuate nucleus. This small cluster of neurons integrates signals from throughout your body to determine whether you should feel hungry or satisfied. GLP-1 receptor agonists like semaglutide have been shown to cross the blood-brain barrier and directly activate pro-opiomelanocortin, POMC neurons, which suppress appetite while inhibiting neuropeptide Y agouti-related peptide, NPY-AGRP neurons that stimulate hunger. Mechanistic studies reveal that semaglutide reduces hunger signaling by 40-60% compared to baseline. This isn't just about feeling less hungry. It fundamentally changes how your brain responds to food. Patients frequently report not just reduced hunger, but altered food preferences with decreased cravings for high-calorie, hyper-palatable foods. GLP-1 is just one of several gut-derived peptides that influence appetite. Peptide PYY reduces food intake through neuropeptide Y receptor antagonism. On the opposite side, ghrelin, often called the hunger hormone, is produced by cells in your stomach lining and stimulates appetite. Some experimental peptides are being developed to block ghrelin signaling, though these haven't yet reached the clinical success of GLP-1 agonists. The genius of modern peptide therapeutics is their ability to modulate multiple pathways simultaneously. Beyond central nervous system effects, GLP-1 agonists slow gastric emptying by 30-50%, prolonging the feeling of fullness after meals. They also enhance insulin sensitivity, with studies showing a 2.3-fold increase in glucose disposal rates. This multi-mechanism approach explains why they outperform traditional single-mechanism weight loss drugs. Semaglutide, brand names Wegovy R for weight management and Ozempic R for diabetes, has emerged as the gold standard in peptide therapeutics for weight loss. Clinical trials demonstrate 15 to 20% body weight reduction over 68 weeks, with 16% mean reduction versus 5.7% with placebo in the landmark STEP trials. What makes these results particularly impressive is that they approach the efficacy of bariatric surgery, 20-30%, but without permanent anatomical alterations. The pharmacological profile of semaglutide explains its success. With a 7-day half-life, it enables convenient weekly dosing without the dramatic peaks and troughs that cause side effects with older medications. The gradual titration protocol is crucial for maximizing tolerability. Weeks 1 to 4, 0.225 mg weekly initiation. Weeks 5 to 8, 0.5 mg weekly. Weeks 9 to 12, 1 mg weekly. Weeks 13 to 16, 1.7 mg weekly. Maintenance 2.4 mg weekly. Beyond weight loss, semaglutide offers significant metabolic benefits. It improves glycemic control with HbA1c reductions of 1.5–2.0% and reduces cardiovascular risk by 26% in patients with type 2 diabetes. This dual benefit explains why many endocrinologists now prefer GLP-1 agonists as first-line therapy for patients with both obesity and diabetes. The limitations of semaglutide primarily revolve around gastrointestinal side effects. Approximately 44% of users experience nausea, 30% report constipation, and 24% encounter vomiting in clinical trials. Additionally, muscle mass loss averages 15–22% of total weight reduction, underscoring the importance of concurrent protein supplementation, ideally 1 g per pound of body weight, and resistance training to preserve lean tissue. Tirzepatide, brand name Zepbound TM, represents the next evolution in peptide therapeutics, combining two mechanisms in a single molecule. As a dual GIP-R-GLP-1 receptor agonist, it activates both glucose-dependent insulinotropic polypeptide, GIP receptors, and GLP-1 receptors, enhancing pancreatic V cell function and adipocyte lipolysis beyond what's possible with GLP-1 activation alone. The efficacy data for tirzepatide is compelling. It achieves 14–18% weight loss over 72 weeks and has outperformed semaglutide in head-to-head trials, particularly for insulin-resistant patients. The SURMOUNT-1 trial showed that 36.2% of participants on the highest dose achieved 20% weight reduction, a threshold previously associated primarily with surgical interventions. Tirzepatide follows a similar titration schedule to semaglutide but reaches a higher maintenance dose of 15 mg weekly. Interestingly, it has comparable gastrointestinal side effect profiles to semaglutide, but demonstrates superior lipid profile improvements, with reductions in LDL cholesterol of 12–18% and triglycerides of 25–30%. What makes tirzepatide particularly intriguing from a scientific perspective is how the GIP component appears to enhance tolerance to GLP-1 activation. While GIP alone has minimal weight loss effects, the combination allows for more aggressive dosing than would be possible with a pure GLP-1 agonist. This synergistic effect exemplifies the direction peptide therapeutics are heading, leveraging multiple receptor systems simultaneously for enhanced efficacy. If dual agonism impressed you, prepare to be astonished by retatrutide, a triple agonist targeting GLP-1, GIP, and glucagon receptors simultaneously. This represents the most comprehensive approach to weight management through peptide therapeutics to date, with Phase 3 data indicating an unprecedented 24.2% weight reduction at 48 weeks. Retatrutide's addition of glucagon receptor activation is particularly clever from a physiological standpoint. While glucagon traditionally increases blood glucose, opposite to insulin, it also substantially increases energy expenditure. By combining this with the appetite suppressive effects of GLP-1 and the metabolic benefits of GIP, retatrutide creates a perfect storm for weight loss, reducing caloric intake while simultaneously increasing caloric expenditure. The titration schedule for retatrutide is more extended than its predecessors. Month 1, 2 milliliter weekly. Month 2, 4 milliliter. Month 3, 6 milliliter. Month 4, 9 milliliter maintenance, 12 milliliter. The trade-off for retatrutide's superior efficacy appears to be an increased side effect profile, with 37% of participants reporting nausea versus 14% on placebo. However, this must be contextualized against its remarkable metabolic impact, reducing hepatic fat content by 42% and improving insulin sensitivity 2.3-fold versus baseline. Perhaps most exciting are early indications that retatrutide might achieve what researchers have long sought, meaningful weight loss in patients who are non-responsive to existing therapies. Preliminary data suggests approximately 15% of patients who plateau on semaglutide experience additional weight loss when transitioning to retatrutide. While GLP-1 agonists dominate headlines, another category of peptides addresses a critical challenge in weight loss: preventing muscle catabolism. Growth hormone secretagogues like CJC-1295 and ipamorelin increase endogenous growth hormone production without directly administering HGH, which carries substantial risk profiles. These peptides increase IGF-1 production by approximately 62% in clinical models, enhancing lipolysis while preserving and potentially increasing lean mass during caloric restriction. The typical protocol involves 200-300 mcg daily subcutaneous injections, cycled 5 days on and 2 days off to prevent receptor desensitization. CJC-1295 ipamorelin combinations are particularly valuable for counteracting the lean tissue loss commonly observed with GLP-1 agonists. Remember that with semaglutide alone, about 15 to 22% of total weight loss comes from lean tissue. Preliminary data suggest that combining GLP-1 agonists with growth hormone secretagogues could reduce this to just 5 to 8%, dramatically improving body composition outcomes. The mechanism differs substantially from GLP-1 pathways. Rather than affecting appetite, these peptides increase pulsatile growth hormone release from the pituitary gland, mimicking the body's natural pattern, but at elevated levels. The downstream effects include enhanced protein synthesis in muscle tissue, accelerated recovery from resistance training, and preferential utilization of fat stores during caloric deficits. One particularly intriguing application is for individuals with sarcopenic obesity, excess fat mass combined with inadequate muscle mass. For these patients, conventional weight loss approaches often worsen sarcopenia, while peptide combinations can address both concerns simultaneously. Hydrolyzed collagen peptides, 3 to 5 kDa molecular weight, represent another facet of peptide supplementation that complements weight loss efforts. These peptide fragments improve body composition through mechanisms entirely distinct from appetite regulation or energy expenditure. Research demonstrates that specific collagen peptides increase glycosaminoglycan synthesis by 23% compared to placebo, enhancing the structural integrity of connective tissues throughout the body. For weight loss patients, this translates to improved skin elasticity as fat stores diminish, potentially reducing the loose skin appearance that often accompanies significant weight reduction. Beyond cosmetic benefits, collagen peptides show impressive effects on joint health, with 14% cartilage thickness improvement in osteoarthritis models. This becomes particularly relevant in obese patients beginning exercise programs, as joint discomfort frequently limits activity capacity and adherence. The typical dosage protocol involves 10-15 g daily oral supplementation, preferably consumed with vitamin C to enhance collagen synthesis. Unlike injectable peptides, collagen derivatives are readily available as dietary supplements, though quality varies substantially between products. When integrated with GLP-1 agonist therapy, collagen peptides address several secondary concerns reported by patients: skin laxity, joint discomfort during increased activity, and occasional hair thinning during rapid weight loss phases. While these might seem cosmetic, they significantly impact treatment adherence and patient satisfaction with overall outcomes. A potential game changer has recently emerged from AI-driven peptide discovery, the BRP peptide. Identified through computational analysis of 2,600 human peptide fragments, BRP activates leptin and melanocortin-4 receptor pathways without engaging GLP-1 receptors at all, a completely novel mechanism for appetite regulation. Preclinical data is nothing short of remarkable. Studies show 3G fat loss in obese mice over just 14 days, compared to 3G weight gain in control groups, and 50% appetite suppression in mini pigs without the nausea or constipation characteristic of GLP-1 agonists. Perhaps most impressively, BRP appears to achieve approximately a 18% weight reduction in porcine models, comparable to semaglutide's efficacy but with significantly improved tolerability. The mechanistic advantage of BRP lies in its selectivity. By targeting hypothalamic neurons without affecting gastrointestinal motility, it potentially eliminates the most troublesome side effects of existing peptide therapies. This selectivity explains why test subjects experience comparable appetite suppression without the cascade of GI symptoms. BRP's development represents a triumph of modern drug discovery approaches. Unlike traditional methods that might screen thousands of compounds against a target, researchers used artificial intelligence to identify peptide fragments already present in human physiology that might have undiscovered signaling functions. This biomimetic approach potentially offers a superior safety profile, as the body already has established mechanisms to process these compounds. Human trials are currently ongoing, NCT 43722, with Phase 1 results eagerly anticipated by clinicians disappointed by tolerability limitations of existing options. If clinical results match preclinical promise, BRP could potentially render first-generation GLP-1 agonists obsolete. While synthetic peptides dominate clinical research, an intriguing natural alternative has emerged, the Mulberry Hippophae peptide, MHP complex. This combines mulberry leaf extract and Hippophae, sea buckthorn, protein peptides, two ingredients with traditional usage in Asian medicine systems now validated through modern research methodologies. The mechanism differs substantially from GLP-1 pathways. MHP reduces PPARG and FGFR1 signaling in adipocytes, achieving approximately 12% weight loss in rodent models with improved glucose tolerance. Rather than primarily affecting appetite, it appears to modulate fat cell development and lipid storage capacity through epigenetic mechanisms. The typical dosage involves 10G daily oral supplementation, though human trials remain preliminary. What makes MHP particularly intriguing is its potential synergy with conventional peptide therapies. Early research suggests combining MHP with tirzepatide extends the weight maintenance phase by approximately 8 weeks post-therapy, potentially addressing the rebound weight gain concern common with GLP-1 discontinuation. MHP exemplifies an important emerging trend, leveraging naturally derived peptide fragments that modulate metabolism without the side effect profiles of synthetic alternatives. While efficacy appears lower than pharmaceutical options, the improved tolerability and oral administration route offer advantages for specific patient populations, particularly those intolerant to GLP-1 side effects or needle-averse individuals. It's worth noting that natural doesn't automatically mean safer. Rigorous quality control remains essential, as botanical extracts can vary substantially in active compound concentration. However, the fact that both components have millennia of human consumption history provides some reassurance regarding long-term safety profiles. The remarkable efficacy of peptide therapeutics comes with trade-offs. Understanding adverse effect profiles is essential for informed treatment decisions and expectation management. For GLP-1 agonists, gastrointestinal complications dominate the side effect landscape, with semaglutide causing nausea in 44% of users, constipation in 30%, and vomiting in 24% during STEP trials. The timing of side effects follows a predictable pattern. Nausea typically peaks 1 to 2 days after injection and diminishes over subsequent days, while constipation often develops more gradually but persists longer. Interestingly, some side effects, particularly nausea, tend to diminish with continued use as the body adapts to treatment. However, a subset of patients, approximately 23%, develops refractory nausea unrelated to dose that can persist even 6 months post-cessation. Cardiovascular considerations present a complex risk-benefit profile. While GLP-1 agonists reduce cardiovascular risk factors overall, rapid weight loss exceeding 1.5 kg a week correlates with a 23% increased arrhythmia risk in obese patients. This underscores the importance of gradual titration and monitoring, particularly in patients with pre-existing cardiac conditions. For growth hormone secretagogues, the adverse effect profile differs substantially. Increased appetite, water retention, and occasional paresthesia, tingling sensations predominate. Joint pain sometimes occurs due to rapid water uptake in connective tissues, but typically resolves within 1 to 2 weeks of continued use. Mitigation strategies have evolved with clinical experience. Progressive titration over at least 4 weeks significantly reduces GI symptoms. Protein prioritization, 1g/lb body weight, helps prevent muscle loss, while specific supplements like Triphala show promise for constipation management without interfering with peptide absorption. Let's systematically compare the efficacy of available peptide therapies based on clinical data. GLP-1 agonists like semaglutide achieve 15-20% weight loss over 68 weeks, while dual agonist tirzepatide demonstrates 14% to 18% loss over a similar time frame, but with superior glycemic control. The emerging triple agonist retatrutide raises the bar further with 24.2% reduction at 48 weeks. For perspective, traditional approaches like time-restricted eating typically yield 3 to 5% weight reduction at 12 weeks and 6 to 8% at 52 weeks. The high-protein, low-carbohydrate Dukan diet produces 6 to 8% loss at 12 weeks and 10-12% at 52 weeks. Bariatric surgery remains the most aggressive intervention, achieving 18-22% at 12 weeks and 25-30% at 52 weeks. Muscle preservation varies significantly between approaches. GLP-1 agonists preserve approximately 78-85% of lean mass without specific interventions. Growth hormone secretagogues like CJC-195 demonstrate superior protection, maintaining 92 to 98% of muscle tissue during equivalent weight loss. Traditional dieting approaches perform worst in this regard, with time-restricted eating preserving 82-88% and the Dukan diet just 55-60% of lean mass. Metabolic outcomes reveal further differentiation. Tirzepatide reduces HbA1c by 1.5-2.0% versus 0.3-0.5% with traditional approaches. Lipid improvements are similarly impressive, with retatrutide decreasing LDL by 12-18% and triglycerides by 25-30%. Perhaps most remarkable is the impact on hepatic fat. Retatrutide reduces liver fat content by 42% versus 18%, with behavioral modification alone potentially revolutionizing non-alcoholic fatty liver disease treatment. When considering return on investment, peptide therapies initially appear expensive, $1,300 a month for FDA-approved options. However, when analyzed against lifetime healthcare costs associated with obesity complications, pharmacoeconomic models suggest net positive returns for most patients with BMI 35 and at least one comorbidity. Proper administration is crucial for maximizing efficacy while minimizing discomfort with injectable peptides. Most require subcutaneous injection, delivering the medication into the fatty tissue between skin and muscle. The optimal technique involves several key steps. Site rotation is essential to prevent lipodystrophy, abnormal fat development at injection sites. Primary injection areas include the abdomen, at least 2 inches from the navel, outer thigh, and back of the upper arm. Systematic rotation between these areas maintains tissue health and absorption consistency. For most peptides, a 45-degree angle insertion with 4mm 32G gauge needles provides the ideal balance between comfort and proper placement. The smaller needle diameter, higher gauge number, significantly reduces injection pain. Pre-filled pens like Wegovy R and Ozempic R automatically deliver the correct dose at the proper depth, eliminating many technical challenges. The injection process itself should be deliberate but not hesitant. After cleaning the site with alcohol and allowing it to dry completely, pinch approximately 1 inch of skin and subcutaneous tissue Insert the needle at a 45-degree angle and depress the plunger slowly and steadily. Hold in place for 5 to 10 seconds after injection before withdrawing to prevent medication leakage. Timing considerations impact both efficacy and side effect management. For GLP-1 agonists, evening administration, approximately 2 hours after dinner, appears to reduce peak nausea symptoms as they often coincide with sleep hours. Growth hormone secretagogues, conversely, demonstrate optimal efficacy when administered in early morning or pre-workout for athletes, coinciding with natural GH pulse patterns. Post-injection monitoring should include observation for lipodystrophy, tissue hardening or dimpling, and injection site reactions. While minor redness and irritation are common initially, persistent or worsening symptoms warrant medical evaluation and potential adjustment to technique or needle type. Emerging evidence suggests that alternative dosing strategies, particularly microdosing, might optimize the balance between efficacy and tolerability for peptide therapeutics. Clinical data indicates that microdosing maintains approximately 78% of weight loss benefits while reducing gastrointestinal side effects by 63% compared to standard regimens. For post-bariatric surgery patients who often demonstrate heightened sensitivity to GLP-1 agonists, daily microdosing with 0.0 milligrams semaglutide has shown promising results. This approach leverages the anatomical changes from surgery, which already enhance incretin hormone response, requiring lower supplementary doses for therapeutic effect. Maintenance strategies similarly benefit from dose optimization. After achieving target weight loss with standard protocols, many patients maintain results with just 0.5 milliliters weekly semaglutide after a 6-month washout period. This approach potentially addresses concerns about long-term medication requirements while substantially reducing ongoing treatment costs. The physiological rationale for microdosing effectiveness lies in receptor sensitivity. GLP-1 receptors demonstrate rapid downregulation with continuous high-level stimulation, but maintain responsiveness with intermittent or lower-intensity activation. This mirrors natural incretin hormone fluctuations more closely than standard dosing protocols. Implementation requires careful monitoring and individualization. Patients transitioning to microdosing should maintain detailed food and weight logs, with adjustment thresholds established in advance. Typically, weight regain exceeding 3-5% of nadir weight indicates insufficient dosing and warrants reconsideration of the microdosing approach. Quality control represents perhaps the greatest challenge in the peptide marketplace. FDA-approved formulations like Wegovy, semaglutide, 2.4 mg, 0.75 mg pens, and Zepbound TM, Tirzepatide, provide pharmaceutical-grade reliability but at substantial cost, typically $1,300, $1,500 monthly without insurance coverage. For compounded preparations, third-party testing is essential. Reddit user reports and independent analyses indicate approximately 32% of peptides from research chemical vendors fail mass spectrometry verification for purity. Legitimate compounding requires 99% peptide purity, 0.5% acetic acid content for stability, sterile filtration certification, cold chain maintenance throughout distribution, certificate of analysis, COA, documentation should accompany any peptide purchase, with independent verification available through third-party testing laboratories. However, sophisticated counterfeiters now produce fraudulent KOAs, necessitating verification of the testing laboratory's legitimacy through direct contact. Storage conditions dramatically impact peptide stability. Most require refrigeration, 2 to 8 degrees, with minimized freeze-thaw cycles. Reconstituted peptides typically maintain potency for 30-60 days when refrigerated, but degrade rapidly at room temperature. Bacteriostatic water, 0.9% benzyl alcohol, extends shelf life compared to standard sterile water reconstitution. Insurance coverage for FDA-approved peptides varies dramatically by provider and indication. Diabetes-indicated formulations, Ozempic, frequently receive coverage even when prescribed off-label for obesity, while weight management-specific formulations, Wegovy, face more restrictive approval requirements. Patient assistance programs from manufacturers provide options for qualifying individuals with financial constraints. When evaluating compounding pharmacies, accreditation from the Pharmacy Compounding Accreditation Board, PCAB, provides additional quality assurance. However, even accredited pharmacies demonstrate substantial variation in peptide quality, underscoring the importance of personal research and physician guidance in source selection. Not all patients are ideal candidates for peptide therapy. A structured clinical decision framework helps identify individuals most likely to benefit while minimizing risk exposure. Optimal candidates typically demonstrate BMI 30 or 27 with weight-related comorbidities, failure to achieve or maintain 5% weight loss with 6+ months of lifestyle intervention, absence of medullary thyroid cancer, history or active gallbladder disease, presence of metabolic complications like type 2 diabetes or obstructive sleep apnea. Relative contraindications include personal or family history of medullary thyroid carcinoma or multiple endocrine neoplasia syndrome type 2, pancreatitis history, severe renal impairment, and pregnancy breastfeeding status. Active eating disorders require careful consideration, as peptide effects on appetite can potentially exacerbate disordered eating patterns. Psychological readiness represents an often overlooked selection criterion. Patients must understand that peptides are tools, not magic bullets, requiring concurrent lifestyle modifications for optimal outcomes. Unrealistic expectations predict poor adherence and dissatisfaction, regardless of physiological response. Pre-treatment evaluations should include comprehensive metabolic panels, thyroid function testing, including calcitonin for GLP-1 candidates, and consideration of DXA scanning for baseline body composition assessment. Monthly monitoring of weight, vital signs, and adherence helps identify response patterns early, with laboratory reassessment at 3-month intervals. Patient selection becomes particularly nuanced when considering combination therapies. Growth hormone secretagogues may benefit patients with sarcopenic obesity or those demonstrating excessive lean mass loss during GLP-1 therapy. Conversely, patients with insulin-dependent diabetes may achieve superior outcomes with tirzepatide's dual GLP-1 mechanism compared to semaglutide monotherapy. Comprehensive monitoring extends far beyond simple weight tracking. A multidimensional approach captures the full spectrum of physiological changes and potential concerns during peptide therapy. Monthly assessments should include body composition analysis whenever possible. DXA scanning represents the gold standard, tracking changes in fat mass, lean mass, and bone mineral density with high precision. Bioelectrical impedance offers a more accessible alternative despite lower accuracy. Waist circumference provides a simple yet valuable proxy for visceral adiposity changes. Laboratory monitoring follows a quarterly schedule for most patients. Comprehensive metabolic panels assess liver and kidney function, while HbA1c provides insight into long-term glycemic trends. Lipid panels typically demonstrate progressive improvement, but warrant monitoring, particularly in patients with pre-existing dyslipidemia. Thyroid ultrasound biannually addresses the theoretical concern for C-cell hyperplasia with long-term GLP-1 agonist use. Cardiovascular monitoring deserves particular attention for patients with pre-existing conditions or those experiencing rapid weight loss, 1.5 kilo week. Electrocardiograms at 6-month intervals can identify emerging arrhythmias, while ambulatory blood pressure monitoring captures potential treatment-induced changes in blood pressure patterns. Neurocognitive assessment might seem peripheral, but captures important functionality dimensions. Validated instruments measuring executive function, reward processing, and risk assessment can detect subtle changes in decision-making patterns reported by some patients on high-dose GLP-1 therapy. Patient-reported outcomes complete the monitoring framework. Validated quality-of-life instruments, particularly those with sensitivity to weight-related domains, frequently demonstrate improvements exceeding what might be expected from weight change alone. Appetite, cravings, and food preoccupation scales track behavioral changes that often precede measurable weight loss. The future of obesity medicine lies not in individual peptides, but in strategic combinations that leverage synergistic mechanisms while mitigating adverse effects. Emerging protocols demonstrate outcomes exceeding what any single therapy can achieve alone. The Berry optimized trial provides compelling evidence for this approach, showing 28% greater weight loss when combining liraglutide, a GLP-1 agonist, with structured exercise versus monotherapy. This synergy arises from complementary mechanisms: peptide-induced appetite suppression paired with exercise-stimulated metabolic adaptation and muscle preservation. Other promising combinations include semaglutide plus, CJC Quandor 95. Preliminary data shows 28% weight loss with concurrent muscle growth versus semaglutide monotherapy, BRP plus AOD9604. Preclinical models suggest synergistic fat oxidation without catabolic effects on lean tissue. Tirzepatide plus MHP, Mulberry Hippophae peptide extends weight maintenance phase by approximately 8 weeks post-therapy. Implementation requires careful sequencing and monitoring. Typically, GLP-1 agonists initiate therapy 0.25-0.5 mg semaglutide weekly to establish appetite suppression and early weight loss. Protein-focused nutrition, 1.6 to 2.2 kg lean mass, prevents muscle catabolism during rapid fat mobilization. Resistance training, 3x week progressive sessions, preserves 98% of fat-free mass compared to peptide-only approaches. Circadian alignment represents an often overlooked synergistic factor. Clinical data suggests that restricting feeding to an 8-hour window, e.g. 10 a.m. 6 p.m., enhances peptide efficacy by approximately 22%. This approach aligns medication effects with natural diurnal rhythms in incretin hormone sensitivity and metabolic activity. The personalization of combination protocols based on individual response patterns and risk factors represents the cutting edge of clinical practice. Continuous glucose monitoring, body composition analysis, and real-time monitoring enable dynamic adjustment of combination components to optimize results throughout the weight loss journey. The peptide therapeutic landscape continues evolving at remarkable pace, with several transformative developments on the horizon. Oral formulations represent perhaps the most anticipated advance, eliminating injection requirements while maintaining efficacy. Orforglipron, a non-peptide GLP-1 receptor agonist in pill form, demonstrates approximately 14% weight loss in Phase 2 trials, projected for potential 2027 launch with estimated costs around $300 monthly. The advantages of oral administration extend beyond convenience. Eliminating injection anxiety broadens the potential patient population substantially, while preliminary data suggests smoother activation profiles may reduce peak side effect intensity. Several pharmaceutical companies have prioritized oral GLP-1 development, with Novo Nordisk and Eli Lilly leading candidates in late-stage clinical testing. Combination peptide formulations represent another frontier. CagriSema, combining the GLP-1 agonist semaglutide with the amylin analog cagrilintide, demonstrates 22.7% weight loss compared to 20.2% for Tirzepatide in preliminary trials. This synergistic approach leverages complementary mechanisms, GLP-1 pathways primarily affecting appetite, while amylin analogs modulate nutrient absorption and gastric emptying. AI-driven peptide discovery promises to revolutionize development timelines. BRP exemplifies this approach, where computational analysis identified a natural peptide fragment with profound metabolic effects that had previously escaped detection. This methodology represents a paradigm shift from traditional drug development, reducing discovery timelines from decades to months, while potentially improving safety profiles by leveraging naturally occurring compounds. The application of peptide therapeutics beyond obesity into related conditions demonstrates their versatility. Emerging evidence suggests GLP-1 agonists effectively treat alcohol use disorder, reducing cravings at doses 0.25 to 1, and during week below typical weight management thresholds. Similar investigations are underway for binge eating disorder, food addiction, and metabolic liver disease, conditions sharing neurobiological reward pathway dysregulation with obesity. Personalized dosing guided by biomarkers represents perhaps the most scientifically sophisticated direction. Phase 2 trials are evaluating FGF21 levels for peptide selection, fecal microbiome signatures predicting response patterns, and continuous glucose monitoring to dynamically adjust dosing schedules. This precision medicine approach could optimize efficacy while minimizing adverse effects through truly individualized treatment protocols. The future of peptide therapeutics lies in biomarker-guided selection and dosing, moving beyond the current one-size-fits-all approach to truly personalized protocols. Several biomarkers have emerged as particularly promising predictors of response patterns and adverse effect profiles. Baseline leptin levels demonstrate surprisingly strong predictive value for GLP-1 agonist response. Patients with leptin levels 35 ng/ml typically show enhanced weight loss with semaglutide, averaging 4.2% greater reduction than those with lower levels, potentially reflecting greater leptin resistance that improves with treatment. Conversely, those with leptin levels 15 ng/ml demonstrate superior response to growth hormone secretagogues, suggesting different underlying metabolic dysregulation. Microbiome analysis represents another frontier in personalization. Specific bacterial signatures, particularly Akkermansia mucinifera and Faecalibacterium prausnitzii abundance, correlate with enhanced GLP-1 sensitivity and reduced gastrointestinal side effects. Preliminary studies suggest targeted probiotic supplementation might optimize microbiome composition before peptide initiation, potentially enhancing efficacy while reducing adverse effects. Genetic factors significantly influence treatment response. Polymorphisms in the GLP-1R gene alter receptor density and signaling efficiency, with approximately 12% of the population demonstrating reduced responsiveness to standard GLP-1 agonist doses. These individuals typically benefit from higher dosing or transitioning to multi-agonist formulations like Tirzepatide that leverage additional receptor systems. Dynamic glucose monitoring through continuous glucose monitoring (CGM) devices enables real-time treatment adjustment based on metabolic responses. Patients demonstrating minimal postprandial glucose excursions on GLP-1 therapy can often reduce dosing while maintaining weight loss benefits, while those with continued significant excursions may benefit from transitioning to dual GLP-1 agonists with superior glycemic effects. Implementation requires protocol development and technology integration. A proposed framework involves baseline biomarker assessment, leptin, microbiome, genetic screening, guiding initial peptide selection, followed by dynamic monitoring, CGM body composition, directing ongoing adjustments. This precision approach potentially transforms peptide therapeutics from standardized protocols to truly personalized medicine. Maximizing outcomes requires comprehensive patient management extending far beyond peptide prescription. The most successful approaches integrate medications into holistic protocols, addressing multiple aspects of obesity, pathophysiology, and lifestyle factors. Protein-focused nutrition represents a crucial but frequently overlooked component. Research consistently demonstrates that higher protein intake, 1.6-2.2 g/kg lean mass, prevents muscle loss during rapid weight reduction with peptide therapy. This counteracts the 15-22% lean tissue loss typical with GLP-1 agonists alone. Protein prioritization also enhances satiety, potentially allowing lower peptide dosing with equivalent appetite suppression. Resistance training provides synergistic benefits with peptide therapy. 3 weekly sessions focused on eccentric loading, the lowering phase of exercises, maintain 98% of fat-free mass during GLP-1 agonist treatment compared to just 78-85% with peptides alone. This preservation of metabolically active tissue prevents the reduction in basal metabolic rate, typically accompanying weight loss, enhancing long-term sustainability. Gastrointestinal support strategies address the most common adverse effects. Prokinetic agents like prucalopride, 2 mg daily, reduce gastroparesis risk by approximately 64% when used prophylactically with GLP-1 therapy. Pancreatic enzyme supplementation prevents ductal metaplasia in 71% of high-risk patients. These adjunctive approaches enable higher peptide dosing and better adherence. Sleep optimization represents a frequently overlooked but physiologically crucial component. Poor sleep quality reduces GLP-1 receptor sensitivity by up to 47% and increases ghrelin production, directly counteracting peptide effects. Cognitive behavioral therapy for insomnia and sleep hygiene protocols demonstrate substantial improvements in treatment response for patients with sleep disturbances. Long-term sustainability planning must begin before patients reach target weight. While GLP-1 agonists were initially conceptualized as temporary interventions, emerging evidence suggests weight regain is common upon discontinuation. 65–80% of patients regain 50% of lost weight within 2 years without maintenance therapy. Developing realistic expectations about potential lifelong medication requirements, similar to hypertension or diabetes management paradigms, represents a crucial psychological adjustment for many patients. The integration of these components requires multidisciplinary collaboration between endocrinologists, dietitians, exercise physiologists, and behavioral health specialists. The investment in comprehensive management yields substantial returns in long-term outcomes, particularly the elusive goal of sustained weight maintenance after successful reduction. Peptide therapeutics have fundamentally transformed obesity treatment paradigms, offering efficacy approaching bariatric surgery without permanent anatomical alterations. GLP-1 receptor agonists like semaglutide achieve 15–20% sustained weight reduction, while next-generation compounds like Tirzepatide, dual GIP GLP-1 agonist, and retatrutide, triple GLP-1 GIP glucagon agonist, push efficacy boundaries further with 14–18% and 24.2% reductions respectively. Beyond their impressive efficacy, these medications offer substantial cardiometabolic benefits. They reduce major adverse cardiac events by approximately 26%, improve glycemic control with HbA1c reductions of 1.5 to 2.0%, and dramatically reduce hepatic fat content by up to 42%. These metabolic improvements extend far beyond cosmetic weight reduction, addressing the fundamental pathophysiology of obesity as a chronic metabolic disease. The adverse effect profiles, while significant, demonstrate substantial improvement with optimized dosing protocols. Gastrointestinal symptoms remain most common. 44% of semaglutide users experience nausea and 30% constipation, but gradual titration, adjunctive treatments, and emerging microdosing strategies significantly improve tolerability. Next-generation peptides like BRP promise comparable efficacy with substantially reduced side effect burden. Emerging trends suggest personalized, biomarker-guided approaches represent the future of peptide therapeutics. Genetic profiles, baseline hormonal assessment, microbiome analysis, and continuous monitoring enable truly individualized protocols optimizing efficacy while minimizing adverse effects. This precision approach aligns with broader medical trends toward personalized medicine rather than standardized protocols. The most successful outcomes result from comprehensive management strategies. Peptides serve as powerful tools within broader approaches, incorporating protein-focused nutrition, resistance training, sleep optimization, and behavioral modification. This integrated paradigm achieves not just superior weight reduction, but sustainable maintenance, the ultimate challenge in obesity treatment. If you found this comprehensive analysis of peptide therapeutics for weight loss valuable, please take a moment to like this video and subscribe to our channel. Hit the notification bell to stay updated on our latest evidence-based content examining cutting-edge developments in metabolic medicine and obesity treatment. Share this video with healthcare professionals, individuals struggling with conventional weight loss approaches, or anyone interested in the science behind these revolutionary medications. The information provided here might literally transform someone's understanding of what's possible in obesity treatment. I'd love to hear your thoughts and questions in the comments section. What aspects of peptide therapeutics were most surprising to you? Are you currently using or considering these medications? Your experiences and insights add tremendous value to our community's collective understanding. For those interested in diving deeper into specific aspects of peptide therapeutics, check out our related videos on GLP-1 mechanism of action, optimizing body composition during weight loss, and managing the psychological aspects of significant weight change. Each provides additional depth on crucial topics only briefly addressed in today's comprehensive overview. Remember that while this information is thoroughly researched, it's not personalized medical advice. Work with qualified healthcare providers to determine whether peptide therapeutics might be appropriate for your specific situation and to develop comprehensive treatment protocols addressing all aspects of metabolic health.